Okay, well, good afternoon, everybody, all 79 participants, and thank you for joining us this afternoon for this very important webinar hosted by the Cancer Alliance to discuss the cost of cancer care in South Africa. Before we begin with the presentations and my introduction, I just want to congratulate the Cancer Alliance for these two very important reports that are the subject of this afternoon's webinar. And I can't overstate their importance. My only hope is that these are not reports that sit on the shelf, that we look back on in 10 years' time and say, all the warning signs were there 10 years ago, but we took no action to prepare to treat and prevent cancer in South Africa. So really, these reports need to be a trigger to activism. I think this webinar is also important and timely because for obvious reasons over the last year, we've had an exclusive focus on COVID-19 and the pandemic in the world and in South Africa. But unfortunately, whilst we focused on COVID-19, non-communicable diseases like cancer were not on hold, waiting until we turned our attention back to their prevention and to care. In fact, I think we'll probably hear this afternoon from some of our experts that diseases like cancer have in fact got worse during this period, both in terms of severe slippage in treatment and care, but also in terms of our failure to manage some of the determinants of ill health. For example, quite recently, I did an interview with the heads of acute surgery at Chris Hani Baragwanath Hospital. And they spoke to me about the changing or changes in patterns of disease, late presentation of people with cancers, with diabetes and so on. So we probably have a great deal to do to catch up and to make society aware of the challenges and the dangers that lie before us. So I'm very glad to be hosting this afternoon's webinar, or to be the facilitator for this afternoon's webinar. I'm very excited that we have an outstanding team of experts and activists and doctors to present to us. And I'm going to very quickly go through the program so that you know what is coming in the next hour and a half or 2 hours before we commence with the first presentation. So the first presentation is going to provide us with an overview of these reports, and it will be presented by Jody Wishnia and Emma Finestone from the organization Percept. I'll say a little bit more when I get to introducing them. They will be followed by Dr. Yogan Pillay. It was Dr. Nicholas Crisp, the Acting Director General of Health, on the program, but Dr. Crisp has had to give apologies, and I don't think we could have a better substitute than Dr. Pillay, except that he's not in the Department of Health any longer, and I really think it's critical that the Department of Health hears what has to be presented and said this afternoon. But Dr. Pillay, I'm sure, still has many tentacles into that department and will convey the message as well as presenting his response. And then after Dr. Pillay, we will have Mark Bletcher, also very, very important, from the Treasury. And I think obviously the cost of cancer care and the question of budgeting for cancer care, particularly when one of these reports puts a price tag of 50 billion rand up to 2030, is going to be a crucial aspect to pay attention to. So those will be our three opening presenters. They will be followed by a panel made up of activists and doctors. Activist Linda Greef, Dr. Richard Khanyile, Dr. Lydia Cairncross, and Dr. Sibongile Shabalala from the Treatment Action Campaign, the chairperson of the TAC. And then at 4:25, we will have time to have some discussion with everybody who's participating this afternoon and to process what we've heard. Just two matters of housekeeping. We are recording this webinar. Obviously, the webinar needs to be a resource for those people who can't attend this afternoon, but hopefully a resource for learning for many, many other people about the findings and the discussion that follows. And also, I would ask all people other than presenters to please try and keep your microphones and your videos off so that we can minimize the bandwidth for people who may be struggling with access to signal. So let's kick off with the first presentation. As I said, the first presentation is going to be by the two researchers who put this report together, and I'll introduce them just by reading their bios as sent to me on WhatsApp. So Jody Wishnia, welcome Jody, thank you for being with us. She's a public health specialist who's worked closely with the national and provincial departments of health and the National Treasury in South Africa in policy planning and financial management. She's a clinical background in occupational therapy combined with extensive experience in public financing, costing and modeling. She's currently completing a PhD and so on and so on. In other words, she's quite clever and she knows about health. And then the second person is Emma Finestone. Welcome, Emma. Emma completed her undergraduate in actuarial science midway through a master's in public health at UCT. She's an astute researcher and a highly proficient quantitative modeler, worked extensively with large data sets and is familiar with claims data coding in the private healthcare sector. So two important researchers bringing their expertise and their discipline to bear on this critical human rights question of a burgeoning non-communicable disease and the need for us as a country to ensure the best quality of care and treatment and prevention for people with cancers. So Jody and Wishnia, you have, sorry, Jody and Emma, you have 20 minutes exactly to present your report, and thank you very much, and over to the two of you. Thanks, and thank you to everybody who's with us. Thank you.
Thanks, everyone. Hi, I'm Jody. Really happy to be here. Salome dreamed up this project before COVID was even a thing in all our minds. So we've been going at it for quite a long time. Really happy to be at the end of the process, or maybe it's just the beginning. So the purpose of this project was really about modeling the incidence of 6 particular cancers over the next 10 years: breast, prostate, cervical, lung, hematological, and pediatric cancers. Of those 6, we also modeled the total expected costs for those cancers, excluding pediatric cancers, due to limitations in data. So I am going to assume that people have read the report. I know that might not be true, but we have so little time, and I know you'll want to get to the meat of the results. So I'm just going to take you through 2 very core methods slides so that you can understand and interpret the results section. Emma will take you through the results, and I'll wrap us up at the end with some of the key take-home messages. So in terms of the methods, it's really important to understand that there's quite a dearth of data in the South African sector around cancer. We were able to combine a number of large, credible public and private sector data sets. We received private sector data from the Discovery Health Medical Scheme over a period of 8 years, and public sector data from the National Cancer Registry and a number of other smaller sources. Neither data set is perfect, and the approach we've taken in the model is to blend data sets to arrive at the best statistical forecast that we can with the data that is available. The other important thing to note is that this modeling exercise is incidence-based. Incidence is new cancer cases. In order to forecast based on prevalence, one would need to have data on remission rates, survival rates, death rates for cancer. We simply don't have that information, and South Africa is actually not alone in that. So in fact, the standard internationally in most countries is to forecast based on incidence rather than on prevalence, which is quite different from other disease modeling that tends to use a prevalence approach. Another important point to note is that the costs that you will see are not per annum costs. What we were able to do with the data we had was to look at the total average cost over the entire episode of treatment for a particular person. So when that person, in the year that person is diagnosed with a particular cancer, we calculate the full cost of their care from beginning of treatment all the way to the end, and all of those costs are found in that first year of diagnosis. So when you see a particular cost in a year, the Treasury or the Provincial Department of Health is not expected to be able to pay that total amount in that given year. What this model shows you is the growing cost of cancer care over the next 10 years that we may need to pay between now and, let's say, 2040. The timeline is not completely clear. The other points on the methods before we get to the meat is that we have assumed that the incidence rate remains the same as it has been over the last 10 years. That's really because in the private sector, we see a flatlining of incidence rates because the screening is quite a lot stronger than in the public sector, but also in the cancer registry data, we also saw very minimal increases in the rate of cancer incidence. What we do see in the public sector data as opposed to the private sector data is the very strong relationship between cervical cancer and lymphoma in people living with HIV. And you'll see that play out in the data as we go through the results. The cost of cancer treatment is also important to note. We haven't assumed any changes in the structure of the costs. We've only included inflationary increases over the 10 years. So we've made no assumption that the cost of a particular medicine might change over the next 10 years, even though we know that that very likely could be the case. The last note is that we were very, very fortunate to be able to piggyback off work done by the Health Economics and Evaluation Research Organization, HERO, which is based at WITS. They've done some really, really important work on costing of cancer services in the public sector. For the costs that they had available, we were able to use them in this model as the public sector costs. For cancers that there was no public sector cost available, we didn't have time nor did we attempt to do that costing. We then used an approach of looking at the private sector data and bringing it down in relation to how the other cancers where we have both public and private sector cost data and looking at those relativities and applying the same relativity to the private sector data to bring it down to the public sector estimated cost that we think would be most likely. Lastly, before we get to the interesting bits, is that the model is built in Excel. All of the assumptions can be changed by the user. The results we present today are based on our best recommendations and assumptions, but we are not oncologists. And so we really do recommend that people who are interested in Excel savvy ask us for the model and play around with the assumptions and see what works for your particular context. So on that note, I'm going to hand over to Emma to take us through the results. I think there will be time for questions. So I think we can allow Emma to continue all the way to the end of the presentation, and Mark will guide us on when it's time for questions.
Thanks so much, Jody, and good afternoon, everyone. As Jody said, I'm going to be taking you through the results of the model, which are based on the recommended assumptions that are currently inputted into the model. But as Jody said, the user can change those model assumptions and see how the results are affected. The model results ultimately show that both the incidence and cost of cancer in South Africa are expected to increase over the next decade. So in this table here, we see that the total number of incident cancer cases more than double between 2019 and 2030. And this total number of cancer cases include only the cancers that we forecasted in the model. So you'll see in 2019, we expect around 76,000 incident cases compared to around 154,000 cases in 2030. And this increase in the incidence can be attributed to the fact that the South African population is growing. So the more people there are, the more people who can potentially be diagnosed with cancer. as well as the fact that the South African population is aging. So because of the close association between age and cancer, and specifically that the risk of developing cancer increases with age, we'd expect that as the South African population gets older or ages, more people will be diagnosed with cancer over time. And then lastly, the age-specific incidence rate of cancer, which is the probability of developing cancer at a given age, is also increasing over time. And this is what we observed in historical data. Then moving on to the next slide, the graph that we see here shows the total expected incident cases of cancer for each year by cancer type. So each line represents a different cancer, and you'll see that each cancer is a different color. The solid line shows the total number of incident cases in the country for each year, and the dotted line shows the total number of incident cancer cases in the public sector. And given that the majority of the population is serviced by the public sector, we see that the public sector accounts for the vast majority of incident cancer cases. So that's why the dotted line is very close to the solid line. As you see on the graph, prostate, breast, and cervical cancer have the highest number of incident cases. So that's the green, red, and blue lines are relatively close to the top of the graph. And this tells us that these three cancers place a comparatively large burden on the health system. Then another interesting takeaway from this graph is that the incidence of prostate cancer, non-Hodgkin lymphoma, and cervical cancer are increasing at the fastest rate. And this can be seen on the graph by looking at the steepness of the graph line or of the slope of each line. So you can see that the green, red, and orange lines are the steepest lines, telling us that those cancers have an incidence that is increasing at quite a fast rate. And the reason that the incidence of non-Hodgkin lymphoma and cervical cancer are increasing at such a fast rate can largely be explained by the high prevalence of HIV in South Africa, given that the risk of these cancers is higher in people living with HIV. Then moving on to the next slide, the graph you see over here shows the total cost of incident cancer cases in the public sector only, so only those serviced by the public sector, in a given year by cancer type. And as Jody mentioned, the total cost in a given year includes the cost per person of the entire treatment episode. So that could span over a number of years, but the full cost is attributed in the first year of diagnosis. The increasing costs that we see over time here, so you see that the graph increases over time, we've got time on the horizontal axis, can be explained by the increase in the number of incident cases each year, which is the graph that we looked at on the previous slide, as well as inflationary increases. So the total cost in any given year does include inflation. And on this graph, you see that the hematological cancers have the highest cost to the system, followed by breast and cervical cancer, and then prostate cancer. And in the next slide, I'll explain some of the nuance behind this. So here we see a table that shows the average cost per person diagnosed with a given cancer in 2019. So that was our starting point, and then from there on out each year, the average cost per person increases with inflation. And as you can see, there are differences in the average cost per person by cancer type, which is because of the differences in treatment plans and their associated costs. On average, we see that the hematological cancers are the most expensive to treat, while prostate cancer is the cheapest to treat. So then if we think back to the previous two slides, the high average cost of hematological cancers explain why the hematological cancers had the highest total cost to the system, even though the incidence numbers weren't as high as some of the other cancers. And then conversely, even though prostate cancer had the highest incidence numbers, it's only ranked fourth when it comes to the total costs, because the average total cost per person with prostate cancer is relatively cheap compared to the other cancers considered in the model. Then moving on to the next slide, when interrogating the average cost per person with a given cancer, we also found that the cost differs quite vastly by stage of diagnosis. And in particular, we found that most cancers were most expensive to treat if diagnosed at stage 4, which tells us that earlier diagnosis can lead to major cost savings and really highlights the importance of early diagnosis. Lung cancer is the exception to the rule, as the average cost is highest for patients diagnosed with stage 2 lung cancer, but this is likely because of a lack of treatment options available for patients with advanced stage lung cancer. The following 2 slides are going to draw on some key results from some of the individual cancers, and we're going to start with breast and prostate cancer. The first notable takeaway for breast and prostate cancer is that the private sector data showed a much higher incidence rate than the public sector data. And this indicated to us that there's a higher case finding rate in the private sector. So a lot more of the cancer cases are being picked up in the private sector. The data also showed a high incidence at older ages, which shows the strong association and increased risk of these cancers as people get older. And this specifically means that as the South African population ages, we can expect quite a sharp increase in the number of individuals diagnosed with these cancers. The high proportion of cases with late stage diagnosis in males, which we saw across cancer types, but quite specifically for prostate cancer, highlights concerns around the poor health-seeking behavior in men that we see in men, which ultimately leads to late presentation and late-stage diagnosis. And this then not only has poor implications for patient outcomes, but also for costs, given that we know that late-stage diagnosis translates to much higher costs, not only for prostate cancer, but also for breast cancer and various other cancers. Then moving on to cervical cancer and lymphoma. The vast majority, so around 70 to 75% of incident cases of both cervical cancer and lymphoma occur in people living with HIV. And this can be explained by the fact that the risk of developing these cancers is much higher in people living with HIV. This increased risk is both biological as well as because of overlapping risk factors between HIV and the cancer. So for example, the risk factors for cervical cancer, which is caused by a sexually transmitted infection, largely overlap with that of HIV. And then because of the high prevalence of HIV in South Africa, the incidence of these cancers is increasing at quite a high rate, and the majority of these cases happen in people living with HIV. Given that the hematological cancers, which include lymphoma, are the most expensive to treat, this high incidence of cancers in people living with HIV is a major concern. I'm going to hand back over to Jody just for some last key takeaways.
Thanks, Emma. Okay, so just briefly, just 2 slides to wrap us up. So we've learned a lot. We feel very privileged to have been given the opportunity by the Cancer Alliance to do this work. Really what we did see is that their choice, which it was Cancer Alliance's choice of initially just breast, cervical, and prostate cancer, was astute. These are the cancers that show the highest incidence and really do seem like they need a clear investment case for South Africa. We were able to see very clearly the positive results of a better screening program in the private sector. In the discovery data, the incidence rate is pretty much flatlined over the last 10 years. And the only plausible reason really is that they are able to screen and detect cancers at quite a high rate. And so there aren't a lot of late stage diagnoses. However, when we chatted to a number of specialists in the field, there was a concern around the ethics of suggesting better screening and detection in a system where the supply side has all but collapsed, given some of the resource constraints. So for us, our key best buys or our areas for investment that we would suggest center really on the access to treatment, while prevention activities that we are already doing carry on. We would suggest a focus on some contracting. It also dovetails nicely with our national health insurance ambitions, and seeing how we can come to agreement between private and public sector around rates for particular services, around need, and how to determine who gets to use which services. And we really feel like the late presentation in men in particular is perhaps an area that could be ripe for a partnership approach to cancer care. Some of our key take-home messages are really that cancer is a major public health concern in South Africa. The data does show it. Incidence and costs are on the rise, and we need to watch out if we hope to stem this tide. We feel very strongly that the approach to the cancer incidence and the burden should be married to other disease approaches, that we don't need another conditional grant only for cancer, but rather that the funding that we do have already, either for HIV or for other disease programs, needs to be looked at in a holistic way, as humans present with multiple conditions in the system. And we've seen with HIV that a more comprehensive approach does yield better outcomes for the patient. We feel that because some of the cancers are intimately linked to HIV, there is a case to be made for using some of the HIV conditional grant funding money to make access to treatment more of a reality for those particular cancers. The last thing is really just an urgent call for an improved data collection strategy for the country. It was extremely difficult to get reliable data for this work. We heard from specialists in both sectors some of the difficulties that they have in knowing who their patients are, what to expect, how to forecast. And so really from our perspective, a strategy for data collection and surveillance of cancer and non-communicable diseases more broadly is extremely important for the South African environment. So that's all from us. We're really looking forward to the rest of the speakers and to engaging with everyone.
Thank you very much, Jody and Emma, for excellent presentations and research, and for keeping to time. There's just two questions I'm going to ask you quickly before I move on to the next speaker. One is from me, which is you talk about the ethics of screening when the functional supply side has all but collapsed, I think you said. Would you just unpack that, what you mean by the functional supply side has all but collapsed for people to understand better? And the second question is from Jao Karapina, who says, great presentation. Did you model for variable mortality across all cancers? What impact would it have on your cost estimation? So we'll just stick with those two questions for now. More things may come up in the discussion, but if you wouldn't mind just quickly taking those two before the next speaker. Thanks.
Sure, thank you so much. So on the supply side, really what we mean there is the lack of particularly oncologists and specialist services in the public health sector. We know, for example, in KwaZulu-Natal, in some rural areas in the Eastern Cape, and to some extent even in Johannesburg at the moment, with Charlotte having been closed for the last while, access to treatment has been severely curtailed. And so when we talk about a collapsed supply side, what we really mean is that someone might be diagnosed with a particular cancer, but it may take many months for them to actually be able to access treatment. And in that time, their staging, their severity of disease may actually change. So there is some ethics around asking a provider to diagnose someone, but knowing that provider, knowing that that person may only be treated in a number of months down the line. On the variable mortality, we didn't look at that. I think it would be a very interesting question. Emma, I'm not sure if there's anything you want to add on the variable mortality estimates. Okay, yeah, so we didn't look at that in our modeling.
Thank you. Thanks very much. Again, really excellent. I hope you'll share your slides with the organizers, because I'm sure people here would like to have access to them. There was one other question. I'm not sure if we have time for it, but I'll just mention it. Should the focus be on treatment and add education awareness and reduce the late stage to earlier as it will reduce the cost too. Let's just hold that for the moment. It's obviously an important question. And I'm going to ask now Dr. Yogan Pillay to come in and present. Welcome, Yogan. I'm not going to read through your bio. I've put it on the chat if people want to screen up. But I think Yogan Pillay is known to many of us through Yogan's many, many years as a Deputy Director General in the Department of Health, working on HIV, TB, communicable and non-communicable diseases. And now Yogan is the Executive Director of CHAI, the Clinton Health Access Initiative. Thank you, Yogan, for joining us, and thanks also for making yourself available at less than 24 hours notice to step in for Dr. Nicholas Crisp. Yogan, you've got 10 minutes. Thank you.
Thanks very much, Mark, and thanks to the organizers as well. Oh, I seem to have crashed out on this. Ah, there you go. At least, can you hear me?
We can hear you. You're very clear. Thank you.
Mark, thanks very much, and thanks to the organizers for inviting me. I don't mind that it's the last minute, but this cancer is close to my heart as well, as it is to, I think, most people on this call. And thanks to Jody and Emma as well for their presentation. And I'd like to start by apologizing for the background noise. I'm in the lounge in Durban trying to catch a flight back to Joburg. I think the first point to make is, we have to think about what this 50 million looks like over the next 10 years in terms of progressive realization and how to spread it out. And I'm hopeful that Mark will speak more to that. The key question is, how should we frame this investment? And I think both Jody and Emma gave us some hints about that in the last two slides that they presented. It's fairly clear that we need to worry about quality, equity, and affordability when we talk about access to cancer treatment. And in that context, we need to focus on the continuum of care. And I think one of the questions that, Mark, you put to us was around investment in prevention and awareness. So we've got to focus on the entire care cascade, from prevention, screening, early diagnosis and treatment, as well as palliative care. If we don't do that, we might be investing potentially more than we need to and in the wrong places. The fourth point I want to make is about the high cost of care. It's fairly clear that we are spending much more than we should be spending, both on chemotherapy, on all the oncology meds, as well as radiation oncology. And I think the Spotlight article in December last year was quite poignant in this context, where a Mr. Henny Buerta, who was on medical aid, could not afford the 89,000 rands that he needed for his cancer treatment every 8 weeks. And I think this, brings home, apart from the numbers that Emma and Jody show, what it means at a very personal level. And in that context, I think we have to think about the patents and how we use the patent laws that we have to lower the cost of cancer treatments. We did it with HIV by moving to generics. And the question is, not just for South Africa, but for the region and for the continent, how do we use the experience of HIV and TB, for that matter, to reduce the cost of oncology meds? My next point is about the shortage of personnel, because I think everything we know and what I think the Spotlight article last year, as well as the paper that's been presented, show us that with the current number of radiation oncologists, for example, in the country, and the imbalance in the distribution, no one is going to have either quality, equitable, or affordable access. We cannot continue with 39 radiation oncologists in the public sector and 146 in the private. So clearly, if you just look at radiation oncology as one example, clearly we have a shortage of human resources for the cancers. You might argue that COVID has shown us we have a shortage of human resources overall in the health sector in South Africa, especially in the public health sector. My next point is about, the steady progress we've been making. 5 of the 9 provinces have public-private partnerships. I think, and the one other P that might be missing is the patient-private-public partnerships. So the patient partnerships, I think, are missing. I think we have a few examples of public-private partnerships, especially with respect to radiation oncology. We have increased, the public sector has, and I know this because I was in the department at the time, we increased the number of linear accelerators, for example, in a number of provinces. So slow and steady progress is being made in the public sector, but clearly this is too little and not fast enough. And the other issue, and I think that Jody did hint at this, is that there's significant provincial variability in access. So it's not something that I think we don't know, but I'd like to emphasize it, that the rural provinces have significantly poorer access to oncology services than urban areas. The penultimate point I wanted to raise relates to the second last and the last slide that Jody showed, that we need to change the service delivery platform. The current service delivery platform, where patients are expected to go to services wherever they find them, is clearly not good enough and will not increase access in either rural or urban areas. Key questions are the role of digital health, and in the context of the quantum of money that the model shows us we need to unpack the following. And I think Emma has started doing that in the presentation she made. We need to know what we're going to be treating. We need to know with what, both chemo and radiation therapy, and what prevention measures we will invest in. We'll need to know by whom and for what outcomes. I think those are the critical questions in developing the package of services that we should be delivering under NHI. We did investment cases for HIV, TB, and malaria while I was in the department, and for each of those, we had a conditional grant. Now, I agree with Jody that we need to move away from focusing on individual programs or disease entities and move towards a package of service for each level of care that is really focusing on what the burden of disease is, what we know works and works best, as well as knowing what the outcomes are that we will be buying for the money we are spending. The COVID has shown us that if there's a will to find the financing for health or parts of health services, we can. And the final point I want to make is about data. It is a great pity, and I think it's reflective of the lack of data, that the modeling excluded pediatric oncology. And I would like to strongly suggest that we find creative ways of also focusing on pediatric oncology. That the National Cancer Registry only focuses on a pathology-based service, and data is collected via pathology and the labs, and not from a community-based surveys, is another big challenge. Finally, we have the National Cancer Strategic Framework 2017 to 2022. As we move to developing the new cancer strategy beyond 2022, we need to figure out how best to do it. And I think this excellent work done by Jody and Emma would stand us in good stead in using it to develop the next strategic plan in the context of NHI. I will stop there. Thank you very much for the opportunity.
Thank you very much, Jogan, and that was very, very helpful and very succinct. Again, if there are any questions to Jogan, I'm not sure how long Jogan has before he has to jump on a plane, but put them in the chat because we'll be able to record questions and get answers to them as well. Jogan, I just have one question. I haven't seen any others to you at the moment, and one comment stroke question. Why you started your input by talking about the cost of essential medicines and the use of patent laws to reduce costs. You were in the department for many years. Why are we not using these laws that are at hand to do precisely what you said? And then the second just comment is you talked about the pity of that we didn't model pediatric oncology, and I think that's a very important point. And there's a costing as well of another issue, which is the cost of palliative care, which I think is particularly important in relation to cancers. And it comes to mind because I work with advocates on child palliative care who complain about the complete absence of a commitment to children when it comes to palliative care. So I don't know whether you want to reflect on that as well. If you can just come back to us for another 3 minutes before I move on to Mark Blecher from the Treasury. Jürgen.
Mark, thanks very much for those questions. Well, you know, I think the approach the department took with the access to medicines is to use volumes, and we used the volumes, as you know, Mark, in the context of HIV very well, I think, and we were able to not only leverage better prices for South Africa, but better prices for people all around the world. And I can quote the antiretroviral prices as well as the TB prices, including bedaquiline. We were able to reduce it to 400 rands well before anybody else. And I think we need to. The problem with the cancer drugs, of course, you can't use the same strategy because the volumes aren't that large, and that's also because we are not treating sufficient number of patients quickly enough. So I would really advocate that we move towards a more considered view around the use of compulsory license and patents around it. On the palliative care, I fully agree with you. While I was in the department, we developed a palliative care strategy for the department. But one of the tragedies is that we weren't able to find the money to fund it. So and I think the lesson from that is that we have to be able to find the money when we develop a strategy. Otherwise, it's a bit pointless developing a strategy without the necessary funding. I'll stop there, Mark, and put some in the chat.
Thanks so much, Jürgen. That's really helpful. I hope that we can write up you can write up your input, because they're very important points, including on there's no point having strategies, or there's little point having strategies if there aren't budgets to go with strategies. And I think that is something the Constitutional Court, in fact, said about 20 years ago in relation to housing and the Grootboom judgment, that a reasonable policy has to have a budget attached to it. Which brings us on to our next presenter, Dr. Mark Blecher. Very grateful to have Mark. I put his CV, his bio in the chat, so I'm not going to waste time going through it, other than to say that he's the Chief Director, Health and Social Development in the National Treasury of South Africa, where he has been for many years. And Mark is somebody, I think, is a model public servant in his accessibility to ordinary people like us and me, to whom he always answers the phone and tries to give you answers when you pose questions to him. So Mark, you've got 10 minutes. It's 15:50. Thank you for being with us this afternoon.
Thank you very much, Mark. Can I check? I've tried to wait. I'm trying to share my presentation. I thought I had.
We can see it. We can see.
Oh, you can see the presentation. Okay, that's great. I'll just want to. How do I
go to the slideshow so that we can?
Unfortunately, it's hidden by the toolbar. Oh, there we go. Slideshow. All right, you can see that.
Yeah.
All right. So good afternoon, everybody. Sorry, I had a bit of a nightmare getting in. Normally, I can get onto Zoom very easily, but it just would not let me in today. Anyway, but I'm here with you now. Thank you very much for inviting us. All right. So I'll try to respond directly to the Cancer Alliance and Percept reports that were circulated to us. Talk a little bit about health funding and a little bit about national health insurance, and just some aspects about the way kind of the budgeting process works. So just by way of background, I mean, I think it's obvious to all of us that the burden of chronic diseases is escalating rapidly, not just in South Africa, but in all countries. So NCDs are becoming the major burden of disease. And I think it's also now obvious to everybody that there are huge backlogs due to COVID. So I mean, we've been locked down in COVID for 18 months, and a lot of services have got very behind, and cancer services have got very behind. I think what's also clear from the work that's been done to date here is that there's large inequities between the public and the private sector, and there are opportunities for strategic purchasing, but what I'm hearing is that some of them haven't worked as well as they perhaps could. And I think the question is clearly partly how can government respond constructively to the report? And I was a bit kind of taken aback in being asked to present here, and particularly in the context where Salome said to me, look, she knows that, the budget is under huge pressure. And I think it's useful to think about strengths, weaknesses, opportunities, and threats, although it may sound like a cliche because there's some kind of big negatives, but also some big positives. So, I mean, these numbers you will know on the next slide. They're from Stats South Africa on chronic diseases, and chronic diseases are the orange line, and it's just showing the percentage of deaths.
Sorry, Mark, you just need to move to the next slide. We're still on your opening slide.
Ooh. They're moving on my side. Does someone else want to project from your side? I think Salome or Renelle or some others have the slides because they are moving on my side.
Okay.
Sure, I can get them going for you. 1 second.
Sorry, Mark. Thank you.
Just take yours off then, Mark.
All right, I'm just trying to do that. Is it off?
Yes. Oops.
Renelle?
Mark, are you there?
I'm here.
Yes.
Okie dokie. So just 1 moment. Let's quickly see. It's this to share. All right.
Perfect.
Put
on the presentation mode.
Okay, Mark, what slide were you on? Number 4?
Okay, so this one is just showing the orange line is showing just from Statistics South Africa, the proportion of deaths that are due to chronic diseases. And I think it's obvious to everybody that chronic diseases are becoming our major cause of death, and HIV has been gradually coming more under control. Okay, next slide. Okay, so, I mean, thank you very much for the report to the Cancer Alliance and to Percept. I think we welcome the report. We really always love to see good work. And I mean, this is good work. And it's great to see the detail by cancer, the costing of breast cancer, cervical cancer, all the forms of cancer. It's very good. I think it's the first time we've seen that kind of detail. And we note the report makes projections on increasing incidence, and probably also over the years, there'll be more detection as well as increasing incidence. We note the report deals with public sector projections, not really for the whole country, so it doesn't include the private sector. And thanks to the modelers, they shared the Excel spreadsheets with us this morning, and Jonathan and I were having some discussions with the modelers, Jody and the other colleague, and they were taking us through the model, and it has various scenarios of incidence and various scenarios of unit costs, so that the user can play around with various options in the model. One important thing to mention is that the numbers in the model are in nominal numbers. In other words, they're not adjusted for inflation. So when you come through to 2030, the numbers look very high, yes, but it's partly because of the many years of inflation in that. With this kind of actuarial costing, it's important to note that it's an actuarial costing, but it's not actually a plan in a sense. So, it doesn't say this unit should be opened up in this hospital at this cost. But just to say that that this work obviously can contribute a lot to a formal investment case and budget bid. So the work is very useful. Next slide, please. So this slide just takes the nominal numbers in the report, which I guess Jody would have showed you on a slide, And Jonathan just converted it quickly into real prices. I guess this is probably 2020 prices. So whereas in the main report, it shows in nominal prices increasing from 16 to 70 billion, or I think 55 billion in one scenario, or some subset of the data. If you look at it in real prices, it's an increase from 16 billion to 36 billion. So it's a 20 billion increase, which it is a big increase. You know, there's no question, finding 20 billion is a lot of money. But when you look at it like this over 10 years, you know, the numbers start becoming much more manageable. You know, when not to say that necessarily it's easily budgeted for, but it's just to say that it's important to look at it in this real way, and the numbers start becoming, you know, you can start thinking about this in a more realistic way. Okay, next slide. So this is two examples. So in our experience in the Treasury, a lot of these things are not necessarily just the money. In fact, the money is just part of it. A lot of it is the management and governance. And here's two examples. So we work quite closely with the health sector on the introduction of the HPV vaccine. It was introduced in 2014 through an indirect grant of about 200 million rand. By 2018, the funding has been transferred to the provinces as a component in the HIV grant. And because you have to get to schoolgirls, so they're not in facilities, you've got to go out to them. But generally, I think the program has gone well. But now if you contrast it to this, as part of the National Health Insurance grant, the Treasury was asked to support a conditional grant component for oncology, and we did, and it grant. And this indirect NHI grant originally had 4 billion rand, not just for oncology, for a whole lot of areas. But now over the last kind of 4 or 5 years, there's been very poor spending on this grant and weak management of this grant. Can't see that this grant is working. And in fact, the department asked last year to shift the indirect grant, which is a grant managed by the national department, to the provinces, which they shifted part of it, but they kept part of it at national. But then it's still not working very well. So next year, they now want to shift the full amount back to the provinces as a direct, what's called a direct grant component. So this is a bit unlike the HPV vaccine grant, which that worked well. So this one, you know, we heard from the Department of Health, from Jürgen and the colleagues, okay, you know, cancer is a problem, set some funding aside, and granted the amounts are fairly small, although there's still ring-fenced, as you can see here, about 771 million over the 3 years to cancer. But, you know, when one just is not getting excellent reporting and excellent progress, it's quite supporting its increase. And now the department's asking to shift it to provinces to next year, which is probably going to be better because it's not being terribly well managed from the center. Next slide, please. So how does the Treasury evaluate budget bids? So we look at things like the effectiveness of the interventions, the cost effectiveness, the affordability, the implementation capacity, management, and governance. And that's a key problem in the slide I've just talked about. Performance and spending on previous allocations. Again, that's been a key problem. The acceptability of the intervention, guidance from sectoral experts locally and globally, the political forces and the stakeholder groups, and the strength of the implementation plan and costing. Next slide, please. This is just an example. The picture is an example of a cost effectiveness analysis from the HIV investment case. A lot of money, the Treasury's put a lot of money into that investment case, obviously over many years. It provided various scenarios, also looked at how you optimize between the scenarios. We supported a TB investment case. We worked to some extent with Jürgen on a hepatitis C investment case, which has not yet come to fruition. And this is an important point, is the experts on a mental health. But this mental health investment case has not gone through the management processes within the health sector. So the health sector has still not presented this mental health investment case to the Treasury, although it's a very good investment case. So again, you know, a lot of these things rely a lot on governance, on strong managers, on strong people who can drive these programs. Next slide, please. Okay, just a couple of slides on national health insurance. So when you start looking at really big money, like 20 or 30 billion for oncology. National health insurance is potentially an important vehicle for that, because national health insurance, if it finally is implemented, could really change the funding trajectory for the sector. This was just some initial gaps, and it's not for the full national health insurance, but it suggested that there were shortfalls of 33 billion, 55 billion, and 71 billion over a couple of years. As I say, this was just for a subset of initial interventions. All right, let me not, because of time, let me just continue. Next slide. Now, under national health insurance, there needs to be a benefit package, which the current public sector doesn't have very strongly, although it does have some standard treatment guidelines and essential drug lists and so on, but it doesn't have a formal benefit package. And also, it should have a more formal health technology assessment system, which is also fairly weak in the existing system. And given that a lot of the cancer interventions are fairly expensive, it would be quite good to put some of them through formal HTA, but the institutional capacity for that is also important. Also, because oncology is highly specialized, it's an area that the specialists and the national department needs to put in place a lot more clearer norms and standards. How many radiotherapy sites do you need? What type of equipment? How we perform? What are these norms and standards? How is one performing against them? Next slide, please. So just, one of the things about strategic purchasing is that in an environment where a lot of the resources, as was said, like the radiation oncologists are in the private sector, under NHI, potentially one should be able to do strategic purchasing. And, I'm hearing that it's happening to some extent with oncology and maybe not that well, but that is one potential advantage of NHI, is one could purchase from a mixed public and private platform. Next slide. Okay, so I don't want to go through these slides actually, and Salome knows these points. The whole government is under a lot of pressure. The GDP dropped 7% with COVID, about 300 billion was tax revenue was reduced. It came through to expenditure. The health budget has been reduced. You can change to the next slide. This is showing the health budget in since the 2000 year in real per capita terms. You can see there was a somewhat an increase, about a 20 billion increase in 2020, but then substantial, essentially cuts to the health budget going forward for the next 3 years, which are a threat to these types of services. But I don't want to dwell on these cuts, because it's very important, if one knows where one's heading and one's got a clear plan, one tries to address these over time and also through the budget over time. Next slide. This is just a slide comparing South Africa in the blue against a lot of other upper middle income countries across kind of 4 financing indicators. And generally, South Africa is not a bad fund of health compared to a lot of upper middle income countries, but our outcomes are a lot worse, and probably our management is weaker. Next slide. So I think Jogan and the previous speaker talked about the advantages and disadvantages of conditional grants and earmarking. There's some advantages to it, there's some disadvantages to it, whether you want to set aside and ring fence money separately. And sometimes we do it, but then you find that, as we've done here, a year or two later, the ring fence money is not necessarily being managed that strongly. Also, the changes in the reimbursement system, for example, to diagnosis-related groups, would also perhaps reimburse specific conditions more directly. The costing by percept is very interesting and useful, perhaps the first comprehensive costing of cancer services. It would be useful to supplement this at some point with more work on cost effectiveness. This also links to the health technology assessment work. As I say, fiscal space is extremely constrained, but as I say again, in my experience, if one really put one's mind to addressing a particular problem, you may not have the money immediately, but one looks for it over time if the plan and the management is clear enough. Next slide. These were just some issues that came from the report, which because of time I won't go into now, but just to say this point about the syntaxes. So this is another area that has not been strongly managed. The sugar sweetened beverage tax was introduced. It's raised 2.9 billion. The Department of Health asked for some funding for this. An initial 150 million was allocated, and almost very little of it was spent. And even today, 3 or so years later, only a small proportion of it has been spent. And we know a lot of cancer could link to good health promotion. So we could increase even, the health promotion levy and take more of it into health promotion. But the existing allocations have to be well spent. And that's where the problem comes. Next slide. So in conclusion, I think this is the last slide. A detailed costing exercise is welcomed. It could help to form the basis of a formal investment case. Given the importance of leadership and governance, the engagement of bodies like the Cancer Alliance with key stakeholders like the National Department of Health and the provincial departments of health who run these services is very important. There is potential for increasing funding over time, particularly as the economy strengthens and through NHI. Strategic purchasing does hold potential to create a more mixed public and private provision platform. One needs better management of existing funds. Some of the existing cancer funds are in the National Tertiary Services Grant and in these oncology components. And just lastly, the role of civil society can be vital. For example, TAC made all the difference in ARV rollout. Thank you very much.
Thanks, Mark, for an excellent presentation. We could spend, I'm sure, the rest of the afternoon just discussing your presentation. And the important issues that it arises. Perhaps the Cancer Alliance might have you back at some point for a fuller discussion on financing. I took one particular takeaway. There's a whole numbers, is the critical importance of management, efficient management of programs, efficient management of finances, and the challenges of a shortage of human resources. Can I just ask one question before we move on for a very quick answer? The Department of Health in October 2020 finalized a new national human resource strategy, human resources for health strategy. I presume you're aware of that, but I just wonder to what extent that strategy overlaps with your response here, and whether it is a strategy that has a budget attached to it for coming years.
So a national human resource strategy should, of course, tie to a cancer strategy, an investment case, because every strategy has got HR components. But the investment case, although some of us worked on it as individuals, has actually never been tabled with the National Treasury. It's never been formally submitted to the National Treasury or tabled, or any requests arising from the strategy. So it's difficult to comment formally on the strategy because it hasn't been formally tabled with us.
You say the human resources for health strategy has never been formally tabled? With the Treasury, no. Most peculiar. One would think, given the central importance of that strategy. Thank you so much, Mark. I don't see any questions in the chat, but I would imagine that aspects of what you've presented will be coming up in our panel now. So we now have a panel with 4 speakers. I'm going to ask the speakers to please, because we're running 20 minutes late, keep your comments to 5 to 7 minutes, maximum 7 minutes each. I'll butt in if you go over 7 minutes. So flag your critical points. I'm going to put the panelists' bios in the chat rather than wasting time. So we're going to start off with Linda Cairncross. We're going to follow with Dr. Richard Khanyile, then Dr. Lydia Cairncross, and then the TAC chairperson, Sibongile Shabalala. And please, colleagues, try and do stick to time. Linda.
Thanks very much, Mark. Yeah, thank you for the opportunity. I want to just say that today is a really proud moment for us. And for the first time, we've managed to use evidence-based research to help us inform advocacy initiatives, and took a real step towards trying to get away from the ordinary advocacy, looking at what are the problems, but really researching it in an evidence way so that the data can be used for planning. So we are tired of talking about what the crises are. We know what the crisis is. We want these reports to be about finding solutions, looking at the real burden, knowing what that is, and then stepping up and setting forums where we can really discuss solutions together with all the stakeholders. We have specifically not made recommendations because I think it would be presumptuous of us to do that. But if we form solution tanks where we can at high level talk about solutions and come up with the calls that that Jürgen spoke about and that Mark spoke about now, for investment cases, etc., I think we will go a long way to find get to action sooner rather than later. So we are calling on civil society and all health stakeholders to step up, to stop talking about problems, but become part of the solutions. So in our call to action, we are committed to help stakeholders to come together. And we hope to partner with CHAI, or we are partnering with CHAI to set up these solution tanks. We do not only need a possible funding of 50 billion, but we need the political will. We need a roadmap, definite plans with measurable outcomes. We need governance, integrated planning, and service delivery to be designed across the continuum of care. And we want to be sure that these plans that we make are of high quality and has a value-based approach, so that we know that the outcomes will be really a good bang for your or good money's worth. We need we definitely need public-private partnerships where the patient is at the center of that partnership, thinking about really changing our service delivery model. And we need effective data collection, and we really want to call for that. Thank you.
Thank you so much. That's Linda. That's very, very helpful call to action. We will come back to that in the discussion. I'm moving straight on now to Dr. Richard Khanyile, whose very brief bio. I think what's most important to say about Richard is that he's head of medical oncology at Biko Academic Hospital at the University of Pretoria. Richard, over to you.
Thank you, Mark. I hope you guys can hear me.
We can. You're clear.
I would like to thank Emma and Jody for a good work that they've done, and I would also want to thank the Cancer Alliance for making this possible. There are few points that I would like to highlight. Firstly, these projections, they show us the steep road ahead. And that steep road ahead is possible if the government can start planning now. The government can't do it alone. It needs the partnership. At the center of the partnership, we've said always that it should be a patient, but all the other partners, the private companies that need to come in, they need to be brought in by the government so that the government can show the way forward. Otherwise, you will end up with a fragmented pocket of excellence that are not talking to each other. So I would like to see the government doing that. And the other thing that this project has done as well, it has shown that it's possible to start now to plan for human resources if nothing else is done for the projections that is in 2030. If the government will also be required to start now working on those graphs to make sure that they don't reach those catastrophic levels. One of the things that is clear on this data is that if you do the screening and you pick up these cancers early, not only you keep your doctors happy because the load of work is cut, you are also helping the fiscal. You are making sure that the budget can be used in other areas because you will be cutting the cost quite significantly. And without any research, this project tells us that without any research, this is the research that is supposed to have been funded and been run by the government in anticipation of what might be coming in future. And to hear a spokesperson from the government saying this is the first time they understand what it will cost to run cancer in 2030, I feel bad about that. But we are not going to throw in a towel. I think this is a call for all of us to start planning. Screening will help. Human resources we need. Management, strong management for this project is just crucial. And on those notes, I would like just to stop there, Mark.
Thank you, Richard. Very, very powerful words as well. And thank you for the work that you do at Biko Academic Hospital, working in a public hospital on cancer. Thank you very much, Richard. Our next panelist is also working in a public sector hospital, Lydia Cairncross, Head of Surgical Oncology Unit in the Division of General Surgery at Groote Schuur, focusing on caring for patients diagnosed with breast, thyroid, and soft tissue malignancies. From Richard, we go to Lydia. Hi, Lydia, and over to you.
Hi, Mark. Thank you very much, and thank you to Cancer Alliance for this invitation. With the short time that I have, I was going to mention the 5 costs besides the monetary cost of cancer, which I won't have time to talk about in detail, but they were, first of all, the cost of the human face of the cost of cancer, which I think we must always bear in mind, which is the young woman with an irresectable endocrine malignancy that I saw yesterday, who's waited 6 months for a diagnosis. It's the patients with the fungating tumors who present too late for surgery. It's the patients with breast cancer who are struggling to access trastuzumab within our public healthcare system. And we're really here to talk about those stories and to highlight them. And I think a cost of cancer report we should also, and has to a large extent, is the platform to bring forward that human face to this. The second cost is the cost of inequality, which I think comes through really clearly in this report. The inequality in treatment between public and private, between rural and urban, between different provinces, and the fact that in South Africa we don't have one treatment guideline for cancer which the whole country follows, which is a standard of care for the nation. This is unacceptable and something that we really have to change when we're planning for cancer care and cancer treatment. There's the cost of pharmaceuticals. How much of our cancer cost is driven by the fact that we don't control and we don't use our patent laws adequately, that the patent laws in fact need to be improved upon to make sure that pharmaceuticals don't have unbridled ability to profiteer from cancer treatments, and that primarily drugs are used for the people's benefit. There's the cost of late diagnosis, which we've heard a lot about, but the cost that I wanted to talk briefly about is the cost of a fragmented health system and a fragmented approach to cancer care, because cancer care is inherently interdisciplinary and multidisciplinary. I'm a surgeon, and people often forget that surgery is about 50% of cancer care. So surgeons make the diagnosis, surgeons need to do the operations which facilitate chemotherapy and radiotherapy. And in my job, I work more with oncologists than I do with my fellow surgeons. But that's only at the level of treatment. We also need an integrated approach at the primary level. So there's a blind spot that cancer is this high-tech, highly specialized disease only, but actually cancer diagnosis starts right at the level of a patient knowing that their symptom, it could be a cancer, and that a nurse at a primary clinic knows that this kind of bleeding is not correct, is not right for a woman in her 50s to bleed in this way, or that this lump could represent a cancer. So that level of education at the level of primary care providers is a major step that we need to take to make sure that we're not only talking about infectious diseases and diabetes and hypertension with our primary care providers, but also what are the top symptoms for the top 5 cancers in our country and how do we pick them up? So some of the strategies we need to do about working in an integrated approach, I think we must be careful of public-private partnerships for a number of reasons. But if we're going to develop a cancer plan, who's going to make that plan? At the moment, there are very few public sector clinicians on the Ministerial Advisory Committee for Cancer Care. I think that if we have a plan for the country around cancer, we need to have the oncologists and surgeons treating patients around the table. We need to have the patients around the table, and we need to have civil society and activists around the table. And government needs to be at the center of bringing that conversation together. At the moment, I've only sat in one meeting with colleagues from other cancer centers in the country where all 8 universities were represented, and it's a meeting that Jürgen Pillay called about 2 years ago. And we agreed to meet every quarter, which has not happened. And we need to be having those meetings. People delivering the care and people receiving the care need to be part of making the plan for how to improve the care. Thank you.
Sure, Lydia. Thank you. Yeah, I mean, you know, it always shocks me how much wisdom and knowledge and experience there is in management of health within the system, within the public healthcare system, but outside of the places where decisions are made on policy and guidelines and priorities and how the health system should work. And this multitude of committees that don't meet. I think, Lydia, you've spoken very powerfully about an agenda of reform and spoken importantly about the importance of the level of primary health care for cancer care. So thank you very much for adding your thoughts from your experience. So the last of our panelists now is Sibongile Shabalala. Sibongile is the chairperson of the Treatment Action Campaign, a powerful woman leader in health, a person living openly with HIV, and one of our finest and most articulate health activists. Sibongile, over to you on the connections between HIV and activism and cancer. I wasn't sure, I think it was Mark Blecher who finished by saying that cancer needs a treatment action campaign. So over to you. Thanks, Sibongile.
Thank you, Comrade Mark, and thank you to Cancer Alliance and the reports that they have launched. I will start by saying, yes, we need more action on cancer issues. And as much as Mark Blecher said, we need treatment action campaign. Treatment action campaign is moving to advocate for cancer issues. Although I feel now we are not yet fully capacitated. Yes, we are working with Cancer Alliance to capacitate our trainers and our branches on cancer issues. However, I just want to talk about few things. I'm starting with education. I think what made us to understand HIV and what made us to where we are in terms of fighting HIV, I know that we have not reached our goal where we see 100% of people living with HIV are on treatment, numbers of people living with HIV dying of HIV. But we have made so much progress on the issues of HIV, and one of the tools that we used, it was treatment literacy. Treatment literacy, it's a powerful tool that we used as HIV activists when we were advocating for treatment. And I think that tool, we need to use it everywhere, and especially when we are talking about cancer issues. For instance, what we are seeing happening on the ground, I agree with Lydia to say cancer issues need to be diagnosed at least from the primary healthcare. We have
Sibongile, we've lost you.
Mark, she somehow may have a data problem. So
Okay.
I'm not exactly sure if we want to perhaps see if she comes back and we can announce the Q&A session perhaps.
Okay. So whilst we're waiting for Sibongile, who's talking about the importance of treatment literacy and the primary healthcare, again, the level of diagnosis at primary healthcare level. Can I ask if there's anybody who has any questions? We still have 3 panelists with us. We still have Mark Blecher with us as well. So now's an opportunity. If you have any questions, please put your hand up and we will happily bring you in, or comments, if you have any very brief comments. Anybody? Is that a stunned silence because of what's been presented this afternoon? It shouldn't be a stunned silence. It's a call to speak and to speak out and to learn more about cancer and about its cost and about the systemic issues that will allow us to treat it. Julia Ambler, I see a hand from you, Julia. Yes, go ahead.
I was reluctant to ask, but since there's not a rush on questions, I represent the palliative care sector, specifically pediatric. My interest was listening that the strategy for human relations hasn't been formally tabled. I wondered if the strategy for palliative care had been. That's a question for Mark Blecher.
Thanks, Mark. You're still with us. One question for Mark Blecher. Any other questions? I did see Linda had put her hand up at one point. If not, Mark, do you want to just come in quickly? Has the strategy for pediatric palliative care been presented to the Treasury?
No, not at all.
Any palliative care policy or strategy?
No, I don't think so.
Thank you.
So I'm sorry.
If I can say something, you know, I think this workshop, or webinar this afternoon just highlighted again for me the importance of having experts plan services and not bureaucrats plan services. And I really hear what our oncologists and surgeons are saying, that we need an expert team. And that's why I want to make an urgent call that when we have our solution think tanks, that the oncologists, the surgeons, the radiotherapists, please step up to attend those meetings so that we can hear your voices, so that we can come up with plans that are credible, that then can be costed and then can be presented to Treasury so that it would make a real investment case. Look at working jointly together with civil society and advocates to really get the core issues that clinicians experience, and including in that the voice of the patients. Very important. We can't have bureaucrats doing the service, or, you know, rendering those services. We need to stand up for our own cases that we have. I want to make an urgent call to this group for working with us.
Thanks, Salome. We're lucky to have Sibongile back. Sibongile, if you can just put your video on. One of the questions while you're away, Sibongile, which you can answer as well as you finish your presentation, was from Julie, who says, is part of our problem that the cancer community is just too nice? I don't hear a lot of anger about poor management of investments and the missed opportunities that this represents. I know TAC was always very polite and calm and so on about what it demanded. So perhaps you can take that into your answer as well. Thanks, Sibongile.
Yeah, thank you. But mostly to do what I can.
Sibongile, we're struggling with you again. So turn off your video, Sibongile, and see if we get a better signal. Sibongile, if you turn off your video.
HIV. Mark, I'm trying to turn off Sibongile's video, but it doesn't seem to work. So let's just see. She is still in. Let's see if I can. Yeah, she does seem to have a bit of a data or connection problem there.
Yes, weather is bad. So
the weather's bad.
Can you?
We can hear you now.
Okay, thank you. So as I was saying, we need patients who are survivors of cancer, who are still suffering from cancer, to come up and tell their stories. That is how maybe the government may be able to listen and understand what we are talking about. But we need more advocacy on issues of cancer, as we did with HIV. I always relate to what we have done as HIV activists. We need to be more vocal, and we need like patients from the ground who can be able to raise up these issues and talk about their experiences and what has happened in their illnesses. But it will be wrong for me not to talk about HPV vaccine. TAC was in the forefront working with other organizations to advocate for HPV vaccines. And from the start, we've been saying you can't give a girl child a vaccine and not give a boy child, because we know that boys are the male are transporters of HPV. And if are not provided with HPV vaccine, then it means we are not fighting the cause, or that we are not preventing everyone. We'll continue to see more of women having cervical cancer, because even the HPV vaccine doesn't reach the rural areas and the deepest rural areas. But I want to close, Mark, by talking about the issues of prostate cancer. We really need to talk about these issues, as we see that men are not reporting to clinics most of the time, and men are dying of prostate cancer. But most importantly, it's education. I'm happy to announce here that last week, as Treatment Action Campaign, we had our sector summit, and from the men's sector, it has come out that TAC will go on the ground, educate men about issues of prostate cancer, and they will always encourage a male men to go to the facilities. Thank you.
Thanks, Sibongile. Any final questions or comments to Sibongile or Lydia or Richard or Linda? We have a few minutes before wrapping up, or Mark, Bletcher, Yogan has left us. Any last, Jody, I see you raised a hand. Please come in.
Thanks, Mark. I just wondered, from those working at the facility level, how difficult or easy it would be to start collecting more robust data on the clients in the system, and what are some of the limitations in the system now? Yeah, so I suppose when we call for a data collection strategy, of course, that always impacts on clinicians, who the burden falls to collect that data in some way. So I'd be interested to hear either if some of those clinicians are already doing some of this data collection, it's just not in the public, sort of the public space, or what some of the thoughts are around it.
Thanks, Jody. Lydia or Richard, if you want to make any comments on that. Also, if there's any other clinicians on this webinar, oncologists who'd like to make any comments, anything that you feel hasn't been said that needs to be stressed, the floor is yours as well. Lydia, Richard, do you have any response?
Yes, I would like just to say that different units around the country, they have their own data that they use within their own silos, and we don't have a national platform where you can tap in and understand the distribution within the country. You can go to Joburg, Gerald Maxeke, probably they will have their own data there that is sitting there, that if you want to tap into it, you might have to go into their system. Steve Biko as well, it will be the same thing. I think when it comes to cancer, you need some form of a national network where that is managed at the government level, where anyone who wants to have a look, of course, you need to have access, given authorization to do that. But you need to have a central collection platform where anyone who wants to understand cancer and the distribution in South Africa can go and tap in those. But in our own department, if I want to know the last 10 years of how breast cancer has performed over the last 10 years, I do have that data. I can punch on it and get the results I want, but they are just for Steve Biko. They don't tell me anything beyond the borders of my hospital.
Thank you, Richard. Lydia?
I see Jeanette's hand is up. Mark, I'll let Jeanette speak to that.
Jeanette?
Thanks, Mark. Thanks, Lydia. So yes, I agree with Richard. I think that at institutional level and sometimes at clinic level, there are quite advanced databases which are actually used. The problem is data collection. But I just wanted to also make the point that I think we can learn a lot from the pediatric oncology population here, because they've got a national database that is circulated between different departments as the keeper of the database, and they enter every single patient who presents with pediatric oncology in the country, which we do not have in the adult sector. So most departments have got their own databases, and some do better than others. The big issue is the data collection and the data entering, which has to be in real time, otherwise it doesn't happen. And you need grants for that. You need people to enter that data into the databases. So there are lots of databases, but not a lot of outcomes-based data. And in the adult sector, no cohesive collection system.
Thanks, Jeanette. I think it's unforgivable that, as Jody just said, that the National Cancer Register data is quite incomplete. We've known that for a long time. If we don't have data, how can we plan and how can we organize? Thank you, Jeanette, for the information about pediatric oncology. Is there anybody, pediatric oncologists with us, who wants to just expand on data collection amongst peds? I'm not, they may or may not be here, but important points have been made there. Lydia, did you want to make any other comment?
I'll hold Mark. I'll hear what others have to say and come in a bit just at the end.
Okay. I'm not seeing other hands at the moment. Jeanette says, Jeanette is pointing out Alan Davidson. Alan? Your hand is up. Go for it, Alan.
Just to help you out with that, we still have under ascertainment on the pediatric side, but at least, as Jeanette points out, we've done the team sport part and got ourselves together. There are lots of obstacles, and in fairness, the advantage we have in the pediatric community is the metric of numbers, because they are smaller, whereas the numbers in the adult domain are much larger. That doesn't mean it can't be done, but it does bring us back to another important thing that struck me. I mean, I really appreciate this afternoon, but geez, if we can't get governance right, there were, Mark, wonderful opportunities, as you point out, but only if there's governance and only if there's a degree of accountability. And that's a tough thing, I suppose, yes, clinicians need to be in these spaces. Lydia's made that comment like beautifully, but at the same time, it actually doesn't help unless we manage to move the cheese. Maybe we need to learn from you, Mark, from the TAC experience. That's the big question. The hemophiliacs are very good, the hemophilia community, at getting treatment. They leverage a massive amount. If you look at hematology budgets, we spend a huge amount on factor. The government listens to them. We need to find a way to unlock that process. It seems like there's more money there that we get access to, Mark. We just have to figure out how to get it. And then we have to make sure we spend it responsibly. Thanks.
Thank you, Alan. And thank you for the references to the TAC and activism. I think it's very important, and we haven't had a presentation on this afternoon, to remember that what we're talking about this afternoon is a right in our constitution, the right of access to healthcare services that belongs to all people. And when we're talking about children, we're talking about a right to basic healthcare services that must include oncology and pediatric palliative care, etc., which is not even a right subject to progressive realization. Every child in this country has a legal right today to basic healthcare services needed to maintain the health of every child. And therefore, the question really is about how do we combine activism with this right, and how do we use it to address not just things like the price of medicines, but the governance systems and the accountability questions that everybody has been talking about. Lydia's hand is back up again now. So Lydia, if you're ready to come in, please do speak.
Thanks, Mark. I just wanted to make, I guess, a comment or expand on two things. One is to talk about a little more on the public-private partnership issue. I think we need to move away from the thought that the public sector needs to be rescued by the private sector, that the way out of our resource limitation is that we outsource the treatment to the private sector. There are numerous problems with that, and I'd love Percept to maybe take on a project to look at the models of PPPs that have existed in oncology in South Africa and how they have worked and or not worked. What we actually need to do is capacitate the public sector, which means opening, funding, and filling posts, which is possible to do. We know that very often we are training specialists for the private sector, and that needs to be reversed. And that capacitation of the public sector is going to be undermined by multiple public-private partnerships. It's a short-term, quick fix band-aid solution, which long-term will put us in a situation which is potentially worse than where we are now. And the second thing, thanks, Alan, is the gap between policy and practice. And the gap between policy and practice, I've got a living example. I spent 2.5 years helping put together a breast cancer policy for this country. It's a beautiful policy, but it has not had any impact on improving women's access to breast cancer care. Why? Because the women who are potentially affected by this do not know about the policy, and the health workers in our clinics, in our day hospitals and in our provincial hospitals don't know about the policy either. In fact, many of the academic institutions don't have access to the policy, and the policy, in fact, wasn't on the Department of Health website. So as clinicians and academics, we have to connect between the policy level and the community, because at the community is where the power lies. It's where the ability to shift power, to move the cheese, actually lies. And that is a powerful alliance that we need to build to connect those two. And when we talk about empowering the health community, it's not only about empowering the users of the health system, but empowering us as clinicians and academics to know how communities shift political power, so that people understand there's a breast cancer policy, which means I have the rights to be seen within 3 weeks if I feel a breast lump. That knowledge needs to get out there, and we can't do that without community health workers, health promoters, health committees, organizations like the TAC, and through platforms like this brought together by Cancer Alliance. Thanks.
Thank you, Lydia. Sibongile, the challenge of treatment literacy, of mobilizing the community, of making people aware of policy and rights. Do you have any suggestions, any advice, or any comment?
You know, as I've said earlier, Mark, that we need to learn from what we did on HIV. We need, as Lydia just said now, to say we need to work with everybody who's working in the community. Treatment literacy, if it's done at a community level, it's very powerful. And when patients understand these policies and understand the treatment literacy behind cancer, that is so powerful because they can be able to advocate for themselves. And learning from what we did in HIV, we also educated nurses and clinicians to say how things are supposed to be done. As Lydia is saying that other academics and clinicians, they don't know about these policies. So it will be easier if we can work together as communities, especially those who are on the ground, as Lydia has said, to say community healthcare workers, treatment action campaign, and other organizations that are working on the ground, not forgetting ward committee members, because also they are part of the community and they can mobilize in community, use those public meetings to educate. So we need everybody to join hands like we did with HIV, even if we can have a national cancer strategic plan that it's publicized and everybody knows about it, so that we can be able to hold each other accountable, more specifically, and hold a government accountable and make them to have a political will when it comes to issues of cancer. Thank you.
Thanks, Sibongile. I don't see any further questions, and I do see that we're pretty much out of time. In fact, we're over time. So I'm going to, unless somebody puts their hand up immediately, draw this very, very important webinar to a close. Salome Meyer, I think perhaps you should come in to close this meeting. Speak on behalf of the Cancer Alliance. You've all done an incredible job in putting these two reports together, in presenting them to government, in drawing them to the attention of people like Mark Bletcher, in helping to unify there shouldn't be such a thing as a cancer community, but for want of a better word, cancer community, in beginning to join the dots to other health and human rights activists. But really, this is urgent, as with so many things. And unless we see activism around cancer that is rude and unapologetic and that makes bureaucrats uncomfortable and politicians uncomfortable, and which shames them and which shows that they are the cause of death and that pharmaceutical companies are the cause of death through their pricing policies on essential medicines, then I'm afraid that the predictions made in the report by Jody and Emma will come true. And we will sit here in years to come and rue the fact that we knew, just as we knew with HIV, that a lot of people were going to die and a lot of people were going to get sick, and we could have stopped it. So Salome, you're the boss. Your parting words to people who have been with us this afternoon, and thank you.
Thank you, Mark. Thank you to every single person that has stayed online and for being part of our journey. This is only just the start. I posted it earlier. We've started the concept of rethink, redesign, re-engineer, but we have to do that in a collective manner. And this is the start of the conversation. We hope that with everybody that has been part of this webinar today, that you will remain part of us so that we can really redesign cancer care within South Africa, and that hopefully in, let us say in 2 years' time, that we can say that we have got a cancer that is fit for the people of South Africa. We have got the absolute expertise in this country. We have got the will, but we need to go and actually show, and that is what this afternoon have showed us, that we need to go and actually take to Mark Bletcher and to the Minister of Health. We need to go and demand our case. Not ask nicely, we need to go and demand our case. I hope that you will all be with us. Thank you very much.
Thanks a lot, Salome. We have the will, we just don't have the political will in government. That's what I would conclude by saying, and the politicians must prove to us that they have the political will to get systems of governance and accountability right, and to prioritize people's lives. I want to thank all of the speakers, the panelists this afternoon. You very much appreciated for your input. Thank you for the work that you do, those of you who are working in the public healthcare system. Please, let's not make this another wretched Zoom meeting that we forget about and move on to something else in a few minutes. Please, let's make a change around cancer care and around healthcare in South Africa that is in keeping with our constitution. Go well, everybody. Thank you very much, and stay safe. Thank you. That's the end of this afternoon's webinar. Thank you.
Thank you.
Thank you, Mark.
Thank you. Bye-bye.
Thank you.